So I think I'm going to start by introducing Dr. McLeod. Dr. McLeod, you guys can see him, and hopefully more people are joining. Dr. McLeod is basically the clinical director of cardiovascular medicine at Mayo Clinic in Jacksonville. He's the past director of the adult congenital heart arrhythmia clinic at Mayo Clinic in Rochester, Minnesota. He is board certified in both adult congenital heart disease and electrophysiology, clinical cardiac electrophysiology. I thought it was hard enough to be an electrophysiologist, but he is unique in that regard, and I think that's very rare. And I would like to hear if he knows of anybody else who has that double board certifications, and that really makes him that much more special. He will be talking to us today about arrhythmia in adult congenital heart patients, and he has a lot of experience in that regard. He is on the writing committee of multiple guidelines and statements, and for the American Heart Association, for the American College of Cardiology, and for the Heart Rhythm Society. We are really very fortunate to have him talk to us today about the lecture I just mentioned. Chris, the floor is yours. We're very fortunate to have you. Thanks for your time.
Thanks so much. It's nice to join you guys. Can you hear me okay?
Yes, we can. I can at least.
So, yeah, I don't know if anyone else has gone through that route, certified in EP, but it happens obviously quite a lot in the pediatric side and just not so much on the adult side.
So how big is your ego, Dr. McLeod? That's wonderful.
I hope not.
All right.
I hope I still don't entertain the ego. So it's been a nice journey. It's two things that I really enjoy doing. I really like looking after adults with congenital heart disease, and I really love EP. So it's been fun, and also really provided by some great mentors in Rochester. So as some of you know, I was in Rochester for a few years, and I've been down in Florida for the last 3 years, and it's been a fantastic transition. And just as an aside, I really enjoyed, there was a heart failure talk the other day. There was also Zoom, and I really enjoyed it. And so
yeah, we enjoyed that too.
I left that thinking that you guys really care about your patients and take good care of your patients. So it's a privilege to be chatting with you today.
We appreciate that.
So the PowerPoint that I present, that I'll present now, or the talk that I'll present, please stop me at any time. And I want it to be as applicable to your practice as possible. Meaning I don't want it to be too heavy in EP, and I don't want it to be too heavy in congenital. I want it to be focused on what the cardiovascular clinician needs to know in this field, because it's growing quickly. So I'm starting off with just a little bit of history here. When I first learned about this cross-circulation technique, it just took me really by surprise. I didn't realize that this had gone on in the late 1960s. And what you can see here is a young child with congenital heart disease, and cardiopulmonary bypass had not yet been invented. And so typically it was the mother that through cannula would be providing circulation to the child or to the baby. And so she was on a bed next to the child while the child was being operated on. And this kind of cross circulation was sort of the underpinnings for cardiopulmonary circulation. And then when that came onto the fore in the late 1960s, and really predominantly in Minneapolis and in Minnesota, what would happen after the procedures very commonly is heart block. Difficult to operate on some of these early cases without resulting in heart block. And this really highlights the intimate links between electrophysiology, cardiovascular surgery, and congenital heart disease. And this you can see here is the sort of one of these first pacemakers. So this is a patient who was operated on by Lilly High in Minneapolis, and that pacemaker you can see is a mobile one, and it's as mobile as long as that AC cord is connected to the wall. And what happened with a lot of the kids is the kids used to die if there was a power failure, which was not uncommon in Minnesota in those days. And here, out of his garage, Earl Buchan was tasked as one of the handymen in the University of Minnesota at the time with creating the first pacemaker. So here's using some circuitry that he found in a popular electronics journal. He built this first pacemaker, which was for the pediatric congenital patients, the Tachycardia fellows, the cohorts that were operated on that would go into complete heart block. And as most of you know, Earl Buchan is the founder of Medtronic. So this was just really, EP really started with pediatric congenital heart disease, and congenital heart disease really started to change its face from here, where you can see in blue all these patients who died early in life, so died before the age of 1. And then when cardiopulmonary bypass started coming onto the fore in the late 1960s, early 1970s, and then surgical techniques improved, and you can see Fontan surgery, prostaglandins, arterial switches, the Norwood. You can see very few patients are now dying before the age of 1 in this cohort examination, and then patients are living above the age of 15. So you've changed the face of these congenital heart anomalies moving forward at around at that time. And here's another look at it from a similar study, also out of Boston. Here you can see the life expectancy really starting to improve and mortality going down. And if you move towards 2020, it's even better. So these are, this is univentricular heart, total anomalous drainage, and atrioventricular septal defect. These are all complex defects, tetralogy of flow. And really, for all of these defects, survival has improved. Still, survival is different for patients with pulmonary atresia and some of the more complex ones, but it definitely has improved. The more complex the underlying congenital anomaly, still the increased risk of mortality. And this is where we are now. I remember when I was first looking at this about 15 years ago as a fellow in Rochester, the kids and adults were equal, about half the amount of, so there was a 1-to-1 ratio, so the number of kids in the US was about the same as adults in the US, and now just 15 years later, we've got this 2-to-1 ratio of adults living with congenital heart disease as opposed to children. We're going to focus in on the adult group. Obviously has implications for management of resources, just to keep up with this, and it is the adult congenital heart disease is the fastest growing sector of cardiology in our enterprise. So from a rhythm perspective, we'll break it up into just 3 sections, and then I'll say a few words on anticoagulation, but a few things to be aware of from an atrial arrhythmia point of view. We'll start off with that. That's the most common reason that these patients will seek care. And we'll speak about devices and sudden death. So atrial arrhythmias, they really are a factor of the fact that these patients are living longer, because it does take typically a while for these atrial arrhythmias to develop. And I'll show you some longitudinal studies for that. And it's looking at as adults with congenital heart disease as a whole, most of these patients, once they've got to adulthood, have at least undergone one operation, and most of them more than that, because they get operated on when they're a baby, and then that repair needs to be readdressed later on. So, and it's the scars, as you see, that are really fundamental in triggering these arrhythmias. They can be very symptomatic. So the patient with a single ventricle and a heart rate of 190 just doesn't tolerate it as well as a patient with a normal heart, and it's the most frequent cause of hospitalization. So if you, this is a very nice Canadian study looking at their population out of Toronto, and if you look at by the time these patients have got to the age of 50, at least half of them have identified atrial arrhythmias, and probably more happening on a subclinical basis. Depends on what the congenital heart disease anomaly is, but the more complex the anomaly and the more scars, so looking at this atrial switch here, where there's a lot of suturing in the atria and also the fontan, the majority of them will ultimately end up with some kind of atrial arrhythmia. And the atrial arrhythmias, as you have seen in your practice, I'm sure, are associated with just high morbidity, more heart failure, and also probably more stroke. From an EP perspective, for those who don't think about EP in these fundamental terms, this is an old conceptual diagram that I keep with me when I think of patients and what's driving their arrhythmia. Substrate is the tissue itself. Is it diseased? Is there a scar there? Triggered arrhythmias, those are, if we're in sort of fundamental terms, that would be pulmonary vein type arrhythmias. So triggered atrial tachycardias from the pulmonary veins. That's why we isolate the pulmonary veins for patients with paroxysmal atrial fibrillation. And then the autonomics are really important regulators. And if I had to guess, 10 or 15 years from now, we'll be ablating them as opposed to the heart. They really can affect electrical conduction in the muscle in a profound manner. And so they are there, in a major way. But for the congenital heart disease patient, especially those who have undergone repair, it's almost always about substrate. That's really what dictates the kind of arrhythmia. So there's a defect there, maybe an ASD or some diseased tissue, and there's a repair which is going to leave a scar. Atrial size just allows for the perpetuation of these reentrant circuits, which I'll show. And then hypoxia, for some of these patients, affects the conduction properties of the atrial tissue. So this is a post-mortem picture of a patient's heart on the left and a normal heart on the right. The patient's heart on the left really just had an ASD. You can't see it here, but there's an ASD there that resulted in significant right atrial dilatation, right ventricular dilatation, volume overload. You can see the left ventricle is the same in both of these pretty much. And so tremendous atrial enlargement just from a simple ASD defect that will allow for perpetuation of some of these circuits. And this is the concept I'd like most of you to walk away from. This is the most common reason why patients with repaired congenital heart disease will develop an arrhythmia. It's really just a diagrammatic illustration around a central lesion. So here is an ASD that's been repaired with a Teflon patch. We've got a valve on the one side, and this is the perfect substrate. So if you had a PAC, just an extra beat, that propagates past the scar and doesn't propagate down here. And so this electrical conduction blocks there. You immediately set up for this mechanism of arrhythmia. And this mechanism of arrhythmia we call reentry. And it's important to recognize this because it affects how we ablate these patients, but more importantly, it affects why we should choose certain drugs for these patients, why we should think of a class 3 drug like Ticastin or sotalol versus flecainide, propafenone, which you would use in the normal heart. So these reentrant rhythms we call intraatrial reentrant tachycardias, but they really are just flutters around a central incision, scar, some kind of area that just does not conduct electricity, and it sets you up for this mechanism. So with that in as a background for the mechanism of arrhythmia, we'll speak about a couple of cases that are not too detailed, but illustrate a few points. So the Fontan is still being performed now all over the world, and in essence, these are surgical procedures for patients who have a single ventricle. If you have a single ventricle, that ventricle is being utilized to pump to the body, and then the rest of the blood is bypassing the heart directly into the lungs. Now, we don't patch the right atrium or right atrial appendage to the pulmonary artery. What we do is we connect a Gore-Tex tube directly from the IVC into the lungs and from the SVC into the lungs. So it's now called a total cavopulmonary anastomosis, but it is really a Fontan. It delivers blood from the systemic venous circulation directly into the lungs, and you essentially bypass the heart. So if someone has a Fontan and they come in with an atrial arrhythmia, this is an important take-home point for anyone who's going to see these patients in the emergency department, is these can, over time, form these big baggy chambers. And within those chambers, it's very common to see these large thrombi. And these large thrombi are because of sluggish flow through this disease chamber. And this is in many patients despite anticoagulation. So if the INR has been 2 to 3 over the last year, these are still patients that you need to do a TEE for before you cardiovert them, because dislodging these big thrombi and letting this go into the lungs is potentially fatal in these patients. So that's the first difference in seeing anyone. If they have a background of a Fontan, make sure, even if they've been therapeutically anticoagulated with one of the 10A inhibitors, thrombin inhibitors, or warfarin, definitely best practice to TE before cardioversion. Obviously,
So,
if the yep.
Can I ask a question, Chris?
Yeah.
This is Brent Fideau. Just a question. What is the current guidelines regarding Fontan patients? Should they empirically be anticoagulated with a 10A inhibitor or warfarin, or is aspirin still sufficient? Or is there, the last time I looked, it was a gray zone.
Yeah. It's such a good question. There's an ongoing study looking at that now. And we do not empirically anticoagulate our Fontans, but the Cincinnati group does, the Seattle group does, Boston doesn't, Montreal doesn't. And so it's really just, as you said, it's a gray area with no real good guidance. Who are the patients that I would anticoagulate? As you know from doing TEEs or even intracardiac echo on these patients, you can see thrombi on pacemaker leads. And those thrombi over time break off, they go into the lungs and they increase the pulmonary pressures, which is not a good thing for this passive flow. So those are the ones that we would anticoagulate, those who have leads in the Fontan, and probably those, not all, but probably those, and we'll get to this a little later, who have atrial arrhythmias. But there's wide differences in practice around the world.
Very good. Thank you.
Yeah. And if you are going to cardiovert these patients, this is data from our group, you're going to have to do something more than that. They're all going to recur at some stage. It's really that they've got diseased substrate. Unless you do something more than just cardioversion, most of these patients are coming back with another episode. So we would have to put them almost always on a class 3 drug or consider ablation. It's another thing to look out for. It's just a practical a point when looking at ECGs and telemetry in these patients. Patients with congenital heart disease do not necessarily, and more common than not, they have slow heart rates. They don't necessarily have tachycardia. So they shouldn't be presenting with a heart rate of 95 beats a minute just because they have congenital heart disease. So here it looks like in some of these leads, it may be easier to see the flutter, but in some of them, not so easy. And it's very common in our practice for us to have an ECG read by our ECG team, or the Marquette algorithm or the GE algorithm, the sinus rhythm at 95 or 100 beats per minute. And it almost certainly is one of these intra-atrial reentrant tachycardias masquerading as sinus. And if you just do Valsalva in some of these patients, or if you give them adenosine, or you somehow affect the AV nodal function, you can reveal these flutter waves more easily. So they don't always have faster heart rates, they just because they have congenital heart disease, and I would look out for this. In this patient here, who has a background history of complex left-sided congenital heart disease and prior surgery, you can see the P waves quite easily. But sometimes you can't, and these patients go from a 2-to-1 ratio of conduction to a 1-to-1 very quickly. And sometimes you can see this, if you can't see the P waves just on the exercise test. Here you can see at baseline heart rate of 100, and they do very little, and suddenly goes from 2-to-1 to 1-to-1. So this step up in heart rate, and almost doubling in heart rate with reaching, just 5 minutes into the exercise test, is reflective of an underlying atrial arrhythmia. You may not see the P waves; they can be buried in the T wave, or in the very wide abnormal QRS. And just to be aware of these potential pitfalls. Here's that patient's ECG. In some of these leads, not so easy to see the atrial flutter, but you can just see the step up when they go 1-to-1. So how do we treat these atrial arrhythmias in adults with congenital heart disease? Well, atrial arrhythmias is, as you all know, in the normal heart or acquired heart disease, do we slow down the rate, or do we use a rhythm control approach? That group of trials like AFFIRM and Heart Cafe has never been done for adults with congenital heart disease, and it won't be done because it's super difficult to rate control these patients. Much easier to rate control atrial fibrillation, but very difficult to rate control a flutter. These are slow flutters, and a slow flutter means it's conducting around the atrium more slowly because of the diseased tissue, because of the big atrium, and it's allowing time for the AV node to recover. And so it's very difficult to block the AV node sufficiently in these patients. So almost always we're moving to a rhythm control strategy. And as a rhythm control strategy, because you want to because you want to prolong refractoriness, you're going to choose sotalol or Tachycardia in these patients. If you have, and this is an intracardiac map of a patient with scar illustrated here in gray, and we have a flutter going around the scar through this narrow isthmus and back up. If you slow conduction with propafenone or flecainide, which is their main action, you'll conduct more quickly down the AV node, and you'll translate 2-to-1 flutter into that 1-to-1 flutter. So you really want to prolong refractoriness so that these extinguish themselves. So sotalol and Tecousin would be fundamental, obviously amiodarone, but we try and avoid that as a first-line agent. So here's an illustration of a case, a couple of cases, just to give those clinicians an idea of what these look like in real time. On the left here, we're just looking at a diseased right atrium. Red is abnormal tissue, almost scar really. Gray is definitely scar. And pink is normal tissue, so very little normal tissue. And there's an area here, what we would call an isthmus, where you can see this wave of electrical activation circulating around that scar and passing through here. So ablation for this patient was quite straightforward. You can see the red dots just linking the scar. And once it's been mapped, very little ablation for some of these patients. Here's another case that, let's go back to that, I did just a couple of weeks ago with some new software, which looks really fancy and cool, but it's the same principle. You can see this wave front propagating around, down, back up through here. This patient had a lot of scar, which you can see here in red. And it was an ablation just from the SVC down here. For those who do a lot of these ablations, what we've done is mark the phrenic nerve here in brown. And any patient who's had cardiac surgery, I've found the phrenic nerve in so many funny places, just because of when the heart is operated on, the phrenic nerve is moved away, and then when it gets stuck back down onto the heart, here you can see the phrenic nerve down at the IVC. We mapped it all the way down here, and we had a small little spot where we didn't have the phrenic where we could ablate. But really make sure that you pace all over the right atrium for the phrenic nerve in these patients. I've found it down near the tricuspid valve. I've found it in many different places. So just be careful in patients who've had multiple surgeries. The phrenic nerve is stuck in funny places. So ablation, I bring up in my discussion with young patients or older patients with congenital heart disease early on, because it allows us to avoid using class 3 drugs with the potential for ventricular arrhythmias, and it allows us to avoid using amiodarone in young patients. And we should really update this. This is an older study, although our data is still pretty similar, that you're able to, if you're going to use ablation as a strategy to treat arrhythmia, get control of the arrhythmia, but there's quite a high recurrence rate. And what we're seeing is this is not a recurrence of that same arrhythmia. We didn't miss it. This is just that they have multiple scars and that there are other arrhythmias that develop. And so we typically take our time, we spend the whole day with one of these patients and look for other scars that can cause arrhythmias further down the road that aren't causing arrhythmias now. Isolate sections which we know have potential for arrhythmias but aren't responsible for the clinical flutter at the time. So maybe the curve looks a little better, but I do tell patients that they're probably looking at another procedure. So we'll switch gears then and just chat for a few slides about pacing in this group. Anatomy is everything here. We've been sent a few patients over the years where the superior vena cava does not make its way down to the heart, and the referring group has tried for hours to try and get something down. This is just a Glenn anastomosis. It just doesn't make it down to the heart. It's been sewn off, so you won't get leads down. So knowing the anatomy is key. And if you don't have any of the operation reports, we do a lot of CTA or MRA or just even a venogram to see what's going on. Obviously, mechanical valves you need to be aware of, but the most important thing we think of is this intracardiac shunting. As we spoke about earlier, leads develop thrombi, and if there is any open ASD, VSD shunt that is bidirectional and shunting from the right into the systemic circulation, those clots on leads, even anticoagulated patients, can shift across into the systemic circulation and cause stroke. So sometimes you have to put a lead down there, but generally we would switch to an epicardial system for those patients who have an intracardiac shunt.
Chris, one question. Sorry. One question on that. We had a case with a restrictive VSD, so not bidirectional, predominantly left to right. How do you still felt like there was a risk of endocarditis, or I was more worried about endocarditis than thrombi, honestly. But what do you, would you put an epicardial lead there, or you have no problems with the lead?
Yeah, restrictive VSD, it's just such a big pressure differential from systemic into the pulmonary circulation where the lead will be. So I'd be okay doing that endocardially, and we've done that. Yeah. You know, it's an evolving field in that there is, as I think you've seen, quite a bit of stuff in Europe now with endocardial LV leads, and I gave a presentation last year, and the Oxford group, who was also presenting at the same setting, if they can't get in a coronary sinus lead, they poke right through the ventricular septum and put an endocardial lead in the LV and put the patient on warfarin. They haven't had any strokes.
Wow.
Yeah, I was amazed. So that's a big, well-known group, and that's their standard go-to. They just drive the lead right through the septum.
I want Al Sheikh to do that next week.
Okay, actually, we have one this afternoon.
Okay. All right. I look forward to those pictures. So I've not had the guts to do that, but I think if you have to, you have to, and if there's heart block and you anticoagulate, it's probably okay, but the data and the recommendations would be to go epicardial if there's right to left shunting. The other thing to remember is that these kids were operated on, well, I guess as these patients as kids or babies, and the heart's grown. So here is a baffle, which is, we've injected some contrast, and it's come down the SVC, and you can see it's formed this beak. So narrowing just as the patient has grown over time, and you can't put leads through this. Here you can see a baffle leak, and another baffle leak is sealed with an A2 plug and an Amplatzer plug. And so this is a procedure that we stage. We don't want thrombi to go across these leaks into the systemic circulation, so seal those off, and then open up that stenosed area with a covered stent before putting leads through that. So just being aware of the anatomy, and for this, which was an atrial switch, a mustard procedure, just doing a venogram or CTA beforehand. So we're going to move into the sudden death arena here. It's a big issue for these patients. They have a 30-fold greater chance of dying. And I tell patients this is the most, with repaired congenital heart disease involving ventricular tissue, I tell them this is the most likely reason why you're going to die, and we have to follow this carefully. There are two conceptual models to think of here, and I put these in different categories. The first is scar-mediated VT. So here is a picture of tetralogy where the repair, which I'll show you, involves an outflow tract patch, and then there's a VSD, and these create very discrete zones of slow conduction between scars. And then you've got the patient has a failing systemic right ventricle. And the right ventricle we'll speak about first. The right ventricle is a very interesting chamber compared to the left ventricle. You can see in this dissection that it's very thin-walled, and it relies a lot on the left ventricle for its contraction. It's an elliptical, crescent-shaped chamber which almost squeezes in a peristaltic manner. And so once the left ventricle starts to fail, the right ventricle really fails. And all of what we know for sudden death prediction and prevention in acquired heart disease from ischemic and non-ischemic cardiomyopathies really revolves around the ejection fraction of the left ventricle. And now we're speaking about a failing right ventricle. It's just a different beast. And we don't have a lot of good data. We're actually just enrolling now patients for a multi-center trial to just get more insight into this. But looking at a group of CCTGA patients, if the right ventricular EF is really poor, they have a higher incidence of sudden death events, but it's really not that clear cut which of these patients need defibrillators and which of them don't. I think that's a difficult group of patients, and they should probably see a congenital heart disease specialist, and feel free to give me a shout anytime. These are patients more than happy just to chat about over the phone or email. The scar-related VT is the one that we see probably more commonly, because tetralogy of Fallot is the most common complex congenital heart disease syndrome. It involves a VSD, an overriding aorta, this narrowed outflow tract, and then you get this right ventricular hypertrophy. And then after it's been repaired, you've got these patches, both here and on the VSD side, that are providing that same substrate that you saw for the atrial arrhythmias, for reentrant arrhythmia. There's lots of published data on really what is going to predict sudden death for these patients, and I've just distilled it down to these four that I think are most important. Once you see the QRS duration going up beyond 180, I really start to worry that's just slow conduction in the right ventricle, and will set them up for reentrant VT. EP studies have been well characterized and predict events. Documented non-sustained VT on Holters, event monitors, loop recorders, we take very seriously. And that post-mortem of a right ventricle really just highlights how important the left ventricle is. As soon as the left ventricular function goes down, we really worry about sudden death in this group of patients. So we follow them closely. We have a lot of them on beta blockers preemptively. Ablation we'll discuss briefly, and then defibrillator or no defibrillator. So because these are discrete scar-related arrhythmias, and here's a diagram from a case that we did where there was a VT just running between this isthmus between the outflow tract patch and the pulmonary valve. Very little ablation was necessary. We could prove block across here. We could prove non-inducibility at the end of the case. These are young patients that may be able to avoid an ICD. So I'm going to just say that again because it's an important distinction with other VT syndromes. For ischemic heart disease, non-ischemic heart disease, you can't really avoid an ICD if someone has VT. But here, data from our group, data from Boston, Amsterdam, these patients do very well and have good outcomes if you can make sure there is bidirectional block and that VT is taken care of. So worthwhile considering ablation as a way to avoid a defibrillator in these young patients. If your patient is going for cardiac surgery, there is data on the cardiac surgeon freezing these isthmuses, and that results in less VT further down the road.
I'm sorry.
Yeah,
Is that
go ahead.
routinely done when I send somebody for pulmonary valve replacement? Let's say they have an end diastolic dimension index of 160, 170. Does a surgeon, when he replaces that valve, routinely put that ablation line in there, or is that not routinely done?
No, it's not routinely done, and we even here with our group who knows the data, the ball gets dropped, and we have to really insist on it with the cardiac surgeon. It's a very quick procedure. I've scrubbed into a few of those. They have these big probes, freeze that area very quickly. The downside is they can't check for electrical block. And so all of our patients who have that, we bring back for an EP study at 12 months and just make sure that that freeze was not pro-arrhythmic or pro-arrhythmogenic, and that it wasn't creating an isthmus of slowly conducting tissue, that it was really blocking that area and making that patient less susceptible.
Okay, thank you.
So this is 20-year-old data now from tetralogy of Fallot, looking at sudden death in this group from England, and this is really the poster child of sudden death for complex congenital heart disease. These group of patients, once they are 30 years out, they have a significant incidence of sudden death. And then new data from our group looking at Epstein's, it's really very similar. If we look at patients who have this right ventricular, right atrial cardiomyopathy, if you follow them long enough, these patients also have a very similar incidence of sudden death. So each of these syndromes, I don't think you need to remember all of them, but as they get into their later years, we have to be more careful. So now looking at the sort of the last element here is what to do about stroke in this group of patients. Here you can see this Teflon patch I showed you earlier with adherent thrombus on the patch. Any foreign material can be thrombogenic, and we can't use the Ch.B to VAS scores for these patients. These patients were excluded from all of those trials. So how do we risk stratify these patients, recognizing that they have a much higher incidence of stroke than the normal population? This is even just the original ASD group. So patients with a simple ASD, high incidence of late deaths. All of these deaths occurred in patients with atrial fibrillation or flutter. This is the current guideline consensus statement, and it's so complex, and with zero data, I just distilled it down into this, and even this has changed, and there will be an update to this, but at least in 2015 they were thinking probably warfarin for complex congenital heart disease and simple congenital heart disease, like and there is a simple meaning a single lesion, that you could use the Ch.B to VAS score. It's so much more difficult in practice, and we hopefully will have some more data out later this year. This has been looked at. We have a big insurance claims database, and we've looked at 400,000 patients over the last year, and so hopefully we can be able to give some guidance. My personal practice is I use vitamin K antagonists of warfarin and NOACs interchangeably unless there's a mechanical heart valve. And the Ch.B to VAS score I reserve for patients who are over the age of 65, who have just your garden variety risk factors, which would be diastolic dysfunction and big left atria. Very often the patient's left heart is normal. And so you've got a young patient with flutter, no Ch.B to VAS risk factor, probably okay in some of these patients to avoid anticoagulation, but it's really a difficult decision. Each of these patients we discuss as a group. Happy to discuss any with you guys anytime. This is something that needs to be made mention of, and it's what we sort of alluded to. If we look at our Epstein's cohort, so we have a very high risk of stroke in our cohort of about 1,000 Epstein's patients. These are patients with right atrial dilatation, right ventricular dilatation, and often surgery on the tricuspid valve. Many of them have an ASD or a PFO, young age for stroke, and these were the risk factors. It wasn't your Ch.B to VAS risk factors. It was, let me go back there, it was age at surgery, but ASD. So the patients with ASDs, and then also this signal for migraines. So PFO, ASD, we're thinking now paradoxical almost for these patients. they've got higher right-sided pressures. Higher right-sided volume lesions, and they will be shifting across any clot from the venous circulation to the systemic circulation. So it's illustrating a different mechanism of stroke in this young group of patients. So we'll wrap up here just with a couple take-home points. For the atrial arrhythmias, don't be fooled that these patients have faster heart rates. We would use class 3 drugs preferentially, or ablation. Be aware of any shunts, especially in the context of pacing, because thrombi in the leads can get into the systemic circulation easily. And then for sudden death and tetralogy, left ventricular dysfunction, wide QRS makes us worried. Should be sending alarm signals if you see that in patients. And then ablation, perhaps we can use that to avoid ICDs in younger groups of patients. Anticoagulation, probably erring on the side of anticoagulation in these patients, but it seems to be a different mechanism. And I'll stop there, and I'll take any questions.